If you are on call as a resident at 2 a.m. A 2-year-old presents with a large, palpable abdominal mass. You open the CT, and you see a massive, heterogeneously enhancing lesion. Your report will decide the next step: surgery, biopsy, or immediate oncology referral. Making the wrong call here changes everything. Is it a neuroblastoma, or is it a Wilms tumor? Today, we are going to make that choice simple. The first question you must ask is, where did this start? Wilms tumor is a renal tumor. It arises from the kidney parenchyma. Look for the claw sign. This is the thin rim of normal renal tissue that appears to claw around the edges of the tumor, arrow. If you see the claw, you are looking at Wilms. Neuroblastoma, however, usually arises from the adrenal gland. It's an extrarenal mass that displaces the kidney downward and outward. If the kidney is intact but pushed away, think neuroblastoma. Growth patterns: encasement versus displacement. Now, look at the vessels. This is the master key for residents. Neuroblastoma is a stealth grower. It is infiltrative. It likes to encase the aorta and the SMA, wrapping around them without necessarily narrowing the lumen. It crosses the midline frequently. Wilms tumor is an expansive grower. It acts like a giant balloon. It pushes the vessels, the liver, and the bowel out of its way. If you see the aorta pushed to the opposite side but not surrounded, that points toward Wilms. This smart art revealed the growth pattern in case of neuroblastoma, where it encased the aorta and/or superior mesenteric artery without necessary lumen narrowing. While in case of Wilms tumor acts as giant balloon, if you see the aorta is pushed to the opposite side but not surrounded, that points toward Wilms. Don't forget the calcifications. On CT, neuroblastoma is calcified in up to 90% of cases. We are talking about coarse, stippled, or cloud-like calcifications. In Wilms tumor, calcification is much rarer, occurring in only about 10 to 15% of cases. If it's heavily calcified, it's a neuroblastoma until proven otherwise. Let's summarize your reading room checklist. 1. Origin. Intrarenal with a claw sign. Wilms. Extrarenal. Neuroblastoma. 2. Vessels. Encasement and crossing the midline. Neuroblastoma. Displacement. Wilms. 3. Calcification, present and coarse. Neuroblastoma. 4. Age, both peak around age 2 to 3. But neuroblastoma can appear much earlier in infants. Remember, catching these signs early is what separates a good radiologist from a great one. If you found this differential helpful, check out my other lecture on ganglioneuroma versus ganglioneuroblastoma to complete your pediatric oncology knowledge. What's the most challenging pediatric mass you've seen lately? Let's discuss it in the comments. I'm Dr. Mohammad El Masri, and I'll see you in the next reading.